Welcome to IPOPI's webinar, Lung Complications in PID. Thank you all for taking the time to join us this session. I am Martine Perjean, IPOPI President, and it is my pleasure to moderate this webinar. Before we begin, I would take the opportunity to thank CSL Behring for making the webinar possible. Thank you very much. The next 40 minutes, this webinar will provide an insight about both infectious and non-infectious lung complication, covering warning signs that may indicate an underlying PID. It is my great pleasure to welcome our guest speaker today, Professor John Hurst from UCL in the UK. John Hurst, you are a professor of respiratory medicine at University College London, and your clinical work is at the Royal Free Hospital in London. You have been involved with the respiratory care of people living with primary immunodeficiency for more than 10 years. You co-chaired the European Respiratory Society Clinical Research Collaboration, GLILD NET, which aims to address the care of people living with GLILD, a rare lung complication in people living with primary immunodeficiency. You are also the chief editor of the European Respiratory Monograph, part of the editorial board of the American Journal of Respiratory and the Critical Care Medicine and the European Respiratory Journal. So you are in a very good position to also explain how PID specialists and pneumologists can cooperate. Welcome, Professor Hurst.
Thank you.
So how will this webinar work? Professor Hurst will soon begin with his presentation. Once the presentation begins, you can post your question in the question tab that you can see on the right-hand side of your webinar screen. After the presentation, we will discuss a selection of questions with both Professor John Hurst and with Dr. Nizar Malawi from Necker University Hospital, Paris, who is also the chair of IPOPI's Medical Advisory Panel. Dr. Malawi will also answer some of your questions in written form, so thank you for raising questions, and thank you, Dr. Malawi, for joining the webinar today. With introductions and explanation done, let's get started. Professor Hurst, the screen is yours.
Thank you very much, Martine, and I'm very grateful to IPOPI for the invitation to speak with you today, and I also acknowledge the support of CSL Behring, without whom this wouldn't be possible. So thank you. Here's my conflict of interest slide, and you've already heard a little bit from Martine about where I work and what I do, but I thought I might provide a little bit of colour on that. So I'm based in London in the UK. My primary affiliation is with UCL, the university, that's a picture top right. But in relation to this webinar, then it's my clinical service at the Royal Free Hospital in London. Bottom right, it's important because I've been the respiratory part of a joint respiratory immunology service at the Royal Free Hospital for more than 10 years now. And it's that which has really fostered my interest and passion about improving the lives of people living with primary immunodeficiency from a respiratory perspective. So I thought about starting with a slide about what I wasn't going to cover. So I'm an adult physician, so everything that I'm going to say today relates to adults and not to children. And since we only have 30 minutes or so for the presentation, and of course there are a huge range of primary immunodeficiencies, the vast majority of my comments and remarks on this presentation are going to be in relation to primary antibody deficiency. And perhaps it's the topic of another webinar to think about PID in children and non-antibody PID, so chronic granulomatous disease. So what I am going to cover, I want to talk about lung disease in primary antibody deficiency, and there are really two areas that we need to speak about. One of those is acute infections, and they're really important, as I'll show you, but in fact the evidence basis for the treatment of those is more limited, and actually we're going to spend most of this webinar talking about the chronic complications within the lung in people living with primary antibody deficiency. And there are really three things which demand our attention. The first is bronchiectasis. The second is something that we'll call GLILD, G-L-I-L-D, and we'll talk a lot more about that a little bit later. And right at the end, I want to say just a few words in one slide about lymphoproliferative disease in the lung in people with primary antibody deficiency as well. So let's get started, but let's get started by asking ourselves a question. And asking ourselves the question is, why is lung involvement so common in primary antibody deficiency? Well, I don't know if you recognize these numbers or not, but if you don't, you probably should, because we're all breathing 12 times every minute, 60 minutes every hour, and 24 hours every day. And if my maths are right, that's 17,280 breaths a day. And with every single one of those 17,280 breaths, we're breathing in things which are at least potentially harmful to our respiratory tract and to our lungs. And those things might be toxins, like air pollution, particulates, or they might be infective particles, bacteria, viruses, fungi. And so fundamentally, the reason why it's so common to see lung involvement in people with primary antibody deficiency is that our lungs are exposed with every breath we take to substances and to microorganisms which are potentially harmful. And of course, it's the job of the immune system to protect the airways and to protect the lung from those potentially harmful irritants. And it's a very complicated system, illustrated in this very nice review figure on the right. But you can see from that a very critical role for the immune system. And so if the immune system is working in a different way, as it is in many people living with primary antibody deficiency, then those defenses are altered. And the end result of that is an increased susceptibility to lung diseases, and lung diseases which can be more significant or more severe. And that's going to be the bulk of the presentation. But that's fundamentally why we're talking about such common manifestations. And actually, that also has an immediate practical consideration. It means that people who are working in respiratory medicine, as I do, need to be very, very aware that we may be the first specialist who's seeing someone with an as yet undiagnosed primary immunodeficiency. And so it's inherent upon us to ask ourselves the question, in everybody we see, could this be PID? And to make that diagnosis and to try and shorten the time between the first onset of symptoms and the diagnosis of PID, which is still too long. So that's one side of this bilateral relationship. But the other side, of course, is that for those people working in immunology as immunology specialists, you also have to have an awareness of the acute and chronic lung complications that can occur as a consequence of that primary antibody deficiency. And so the best way around this for me is certainly to work collaboratively. That's what we've been doing here in London for some time. But working across respiratory medicine and immunology is one way to address both sides of these important challenges. So let's go on then and think about what we're talking about in relation to lung disease. And just a word first about acute infections. Actually, this is pretty much the same as it would be for the diagnosis and treatment of acute lower respiratory tract infections in someone without primary antibody deficiency. If possible, we'd like to guide our treatment using specimens, so previous culture of sputum, for example, or we might consider obtaining specimens in an infection that's been proving difficult to treat or unusual or resistant. So, for example, with BAL or bronchoalveolar lavage. There's consensus evidence from experts, if not real actual evidence, that prolonged courses of treatment may be necessary in people with primary antibody deficiency, so longer courses of antibiotics, for example. And in terms of choice of antibiotic, then we need to think about what the common bacteria are, and they're going to be the same as in people without primary antibody deficiency, so Haemophilus influenza, Streptococcus pneumonia, and so for someone who's not penicillin allergic, at least a beta-lactam antibiotic like coamoxiclav would be a very reasonable choice. Of course, primary immunodeficiency is diverse, and we also need to think about more unusual organisms, viral organisms, and perhaps pneumocystis if there's a cell-mediated component. If someone's on prophylactic antibiotics, then it's good practice, of course, not to use the same class of medicine to treat an acute infection as you were trying to prevent with the prophylaxis. And again, most people would stop the prophylaxis during the acute treatment, restarting it again once that treatment has been completed. So a few words then about the management of acute lower respiratory tract infections. And actually symptoms in people with primary antibody deficiency are really very common. So this is a recent publication. If you look at the chart on the right, you can see that a lot of patients, indeed the majority of patients with primary antibody deficiency, are complaining of respiratory symptoms, notably cough. And when we go on and look at the imaging in relation to that, we can see that that's commonly because of development of something called bronchiectasis. And so we really need to go on and think about bronchiectasis in people with CVID and other antibody deficiencies in a bit more detail. Not everybody develops bronchiectasis though. And in terms of the other main respiratory manifestation or chronic respiratory manifestation of PID, so GLILD, we'll come back to that, as I said, later on, but everybody develops that. And so it's very clear that some people living with significant antibody deficiency can live with healthy lungs. So it's not just the antibody deficiency that's important. There has to be other cofactors. And this slide summarizes a little bit about what we know about those relative cofactors driving a person towards healthy lungs, continued healthy lungs, or perhaps to the development of bronchiectasis, or perhaps to the development of GLILD. And some more recent data, in fact, from our own center by Johannes Sperlich, illustrated here, suggesting actually that it's low IgM in the blood that seems to be associated with a longer term development of bronchiectasis, and pre-initiation of antibody replacement treatment, the lower the IgG level, the more common it was to develop bronchiectasis. So what is bronchiectasis? Well, we define it radiologically as permanent dilatation of the airways. There's an illustration of that on the right of the screen. The airways in green, and airways in the lung on CT scan and in general are usually accompanied by a blood vessel. I've illustrated that in red for you. And the way that you know that an airway is dilated, if its internal diameter, that's dA on the diagram there, is bigger than the accompanying blood vessel, dV. So that's the radiological definition of bronchiectasis in a cross-sectional scan. If we're looking in longitudinal section, we'd see something called tram lines because of thick walls and bronchi that aren't tapering. Sometimes, if the bronchiectasis is really severe, we see that those airways are actually full of mucus, they're not hollow. And if an airway is visible within the outer centimetre or about the outer third of a CT scan, by definition, it's too big. It shouldn't be visible in that portion of the lung. So a CT scan is a way to assess the presence or absence of bronchiectasis. That's what it looks like on an actual CT scan. So if you look at the right lung field there, or indeed bilaterally in the midzones, you can see dilated airways, and you can see airways which are bigger than their accompanying blood vessels, so-called signet ring sign. Lung function test, PFTs, pulmonary function tests, helpful too, but the picture in bronchiectasis can be quite complex because you can have significant bronchiectasis and have normal lung function. You can have an obstructive picture, that's probably the commonest in people with extensive disease, but you can also see restriction, and then could be a mixed picture too. So lung function tests crucial for screening for respiratory disease in people with primary antibody deficiency, but in bronchiectasis you need a CT scan to actually make that diagnosis or exclude it. This is a classic representation of the pathogenesis of bronchiectasis. It's called the vicious cycle, more recently the vicious vortex. And the idea that once you get into this cycle is that it becomes self-perpetuating. So epithelial injury, for example, leads to impaired mucociliary clearance. That leads to airway colonization with bacteria, and that colonization itself goes on to cause further epithelial injury. And the story or the idea behind this diagram is that it doesn't really matter where you get into that cycle, but once you're in the cycle, it continues. So probably the mechanism in people with primary antibody deficiencies, such as CVID, is that they're more likely to have developed airway colonization. But once you're in, the cycle can continue unless it's being managed effectively. And we're starting to understand more about the mechanisms of bronchiectasis in primary antibody deficiency. It's probably related to inadequate antibody responses, resulting in inadequate phagocytosis of bacteria by neutrophils. And so those neutrophils are dying in their airways, they're releasing their toxic granules, and rather than having a beneficial effect on removing the bacteria, that's actually damaging the epithelial cells and resulting in persistence of those bacteria and bacterial colonization. It's likely to be much more complex than that, of course, but it provides a scheme of how we might think about bronchiectasis in primary antibody deficiency. There are recent guidelines to support you in managing people with bronchiectasis, and I illustrate on the right there guidelines produced recently by the European Respiratory Society. They're helpful, they're accessible, and if you're managing people with bronchiectasis, it's a good place to start to look. And in terms of the basic principles of managing somebody with bronchiectasis, then we try and identify a cause and treat the cause where we find one. And of course, in primary antibody deficiency, that means effective antibody replacement. Of course, for most people with bronchiectasis, we never find a specific cause. It's labeled idiopathic, so that becomes a bit more difficult. And in fact, primary antibody deficiency is probably the best example of a cause of bronchiectasis where there is a treatment which changes the course. The next most important management of bronchiectasis is airway clearance, is airway toilet, is physiotherapy to be able to assist that person to clear their respiratory secretions in the most effective way. And most respiratory services for bronchiectasis will have an attached respiratory physiotherapist to be able to show patients how to do that. Exercise and education is important, often delivered as part of a multi-component program called pulmonary rehabilitation, or PR. And if you have access to those programs for your people with bronchiectasis, then they are strongly recommended as evidence-based interventions. When you think about respiratory exposures, hopefully none of our patients are smoking, but supporting them in a quit attempt is important if they do. And we need to think about prompt treatment of infections. So supporting people to manage infections very quickly when they come on is one way of minimizing the damage. And I'll show you some data in just a minute that suggests that that might not be as easy as it sounds. In terms of medicines, we might use antibiotic prophylaxis. There's most evidence for the macrolide family, although of course we have to be careful with side effects and inadvertent consequences, particularly around non-tuberculous mycobacteria, and we sometimes use bronchodilators as well. When we're thinking about the aims of treatment then, we're aiming to minimize symptoms, we're aiming to minimize exacerbations, and so maximize functional capacity through the preservation of lung function. And where I work in terms of primary antibody deficiency, that means as a minimum, we will be doing annual spirometry, and we'll be doing 5 yearly screening CT. So if a CT was normal, we don't normally routinely repeat that for 5 years unless there's a clinical reason to do otherwise. And in people who are producing sputum, then we would regularly send sputum for surveillance to make sure that we're not missing unusual microorganisms or microorganisms which would need something different, perhaps in management, for example, Pseudomonas, or again, non-tuberculous mycobacteria. Just a brief word on emerging treatments for bronchiectasis. There's a lot of research going on around bronchiectasis at the moment, in part because of big national and international efforts. So EMBARK, in particular, the European Bronchiectasis Network has been at the forefront of this, led by James Chalmers from Dundee. And so we're seeing lots of new drug development here. And my message here is really watch this space. So perhaps inhaled antibiotics, antivirals, novel anti-inflammatories coming your way soon and in various stages of trials. People with bronchiectasis have daily symptoms such as cough and sputum, but they're also predisposed to developing respiratory infections that we call exacerbations. And actually, it's the frequency of those exacerbations which seems to be contributing most to poor respiratory health. And that's one of the reasons why we support patients with bronchiectasis, whether or not they have primary antibody deficiency, to look after themselves and to manage those exacerbations as rapidly as possible. But even in patients who have been highly trained and supported to do that, patients are still delaying treatment. Again, forgive me for showing some of our own data here, but you see symptoms on the panel at the top, and where we have OAT, oral antibiotic therapy, coming in at 100%, that's when patients started their oral antibiotics. And you can see that the main stimuli to do that were changes in sputum and cough and upper respiratory tract symptoms. But those numbers represent the percentage of patients with that symptom on any one day. And you can see that for a good 5, 6, maybe 7 days before patients started treatment, those symptoms were beginning to change. So supporting people to better identify and manage their exacerbations when they occur, really important going forward. And we need much more research in this area. Median delay of 5 days before the onset of symptoms to commencing antibiotics. And that's 5 days unnecessary damage going on within the lung. We're knowing a lot more now about the types of microorganisms that cause exacerbations of bronchiectasis, and certainly bacteria are important, and that's why we use antibiotics. But we now see actually that a lot of these events are being driven by viruses, particularly rhinovirus. And of course, that's a hole in our therapeutic armamentarium because we don't have any rhinovirus drugs to control those events. So although we use antibiotics a lot, we should be aware that in primary antibody deficiency, as in general bronchiectasis, a lot of exacerbations may be associated, in fact, with respiratory viruses. A word next on the multi-component assessment of bronchiectasis, or severity scoring, if you like. And there are 2 competing ways to do this. One is called FACED, F-A-C-E-D. The other is called the Bronchiectasis Severity Index, or BSI. Probably the BSI is in more common use. It has an online calculator enabling you to work the score out, and the score is predictive of exacerbations and hospitalizations. And in particular, it asks about the nature of sputum bacteria, and particularly the finding of Pseudomonas in sputum. And our understanding of bacteria in the lung is actually changing very, very rapidly. So it's only about 15 years ago that you could see statements such as one on the left, confidently spoken by experts in the field, suggesting that the lung is sterile. And of course, that's not just true. The lung is open at the nose and the mouth. And as I started off by saying, with every breath that we breathe, we're bringing in microorganisms. But it took the development of culture-independent microbiology, particularly a technology called 16S RNA sequencing, or microbiome, to understand that all of us have bacteria in our lungs all of the time. And the difference between disease and health is not the presence versus absence of disease, it's differences in the different families of bugs that are living there. Here's some new data on CVID bronchiectasis specifically. And I'm showing you this because there are some things on there that we know. We know that low lung function, FEV1, is important. And we know that this bug called Pseudomonas is important. But notice that this data is also suggesting that people with CVID specifically and bronchiectasis may be at higher risk of poor outcomes. And that's really at variance with classic, large, well-conducted studies, such as this classic work from the Cunningham-Rundles group, showing that people with CVID and infection-only CVID have really very good outlook. And it's the group of people with a different sort of lung complication or lymphoproliferative disease who actually have poorer outcomes. So perhaps we need to revisit the importance of bronchiectasis when we come and think about the outlook for people living with primary antibody deficiency and particularly with CVID. But it's the other group that we need to spend a little bit of time talking about. And what I want to talk about next is something called GLILD, or granulomatous lymphocytic interstitial lung disease. And it's probably being seen in about 10 to 15% of people with CVID specifically. It's not seen in XLA. And it's really, I think, best considered the lung manifestation of what really is a multisystem disease. There may be enteropathy, there may be splenomegaly, adenopathy, cytopenias, nodular regeneration of the liver. This is a lung manifestation of this systemic auto-inflammatory, autoimmune condition. And there are some emerging genetic associations, for example, CTLA-4 LRBA deficiency. This is really largely an evidence-free zone, and that's concerning because these are some of the most difficult decisions that we have to make. And so there's been some consorted efforts initially in the UK and more recently around Europe to better understand GLILD, and that started with a definition. A definition presented on the screen there as a lung manifestation of this multi-system component. Next, I want to highlight too that there's a recent series in Frontiers in Immunology, a series devoted to GLILD, and 6 or 7 really great review papers and new data emerging in that series. I just want to really race through actually to highlight some of the features from that. But one is about histology, and it's very clear that histology, what we call GLILD, is very variable. And so it's likely that this is a very heterogeneous disease. And that's important because that means that treatment might be different and prognosis might be different too. There's certainly emerging evidence of the importance of B-cell dysregulation. So we see B-cell hyperplasia as part of the interstitial lung disease in CVID or GLILD. And that might be important because it may be that by assessing that, we can predict the risk of developing it, or that it may become a marker of treatment and or treatment response. And certainly, as we'll see a bit later, medicines targeted against B cells, rituximab, for example, have shown some promise in treating this really very difficult lung complication in GLILD. And those B cells are appearing in bronchoalveolar lavage fluid too. So it may be that we don't need to be thinking about biopsy, but it may be that bronchoalveolar lavage is one tool that could be explored further to guide not just the diagnosis of GLILD, but also the specific phenotype of GLILD, and therefore be used to guide therapy as well. As you heard from Martine, it's my privilege to co-chair something called GLILD Net, and that's a European Respiratory Society clinical research collaboration set up a couple of years ago now, really to bring people together across Europe to try and address some of the problems that we're all having in managing this really very difficult condition. And we've been doing a little bit of work in the field. So one of the things that we did was a survey of clinicians, and what became clear from that is that there's a lot of confusion out there in terms of how to diagnose, how to treat, how to monitor, and a lot of concern about the risks and benefits of different treatments. For example, high-dose corticosteroids. So this is an area crying out for research, which is one of the things that GLILDNet wanted to do. In terms of treatment, also included in that recent Frontiers series is this very nice systematic review from Joris van Motfront and colleagues, really for the first time bringing together all the available evidence to treat GLILD. And somewhat depressingly, the conclusion of that is that we could not draw definitive conclusions regarding optimal treatment. The data are, as such as they are scarce, are small studies. And if we're really going to change outcomes in GLILD, we really need international registries, standardized tests, and ideally large-scale trials to address some of these challenges. This then is one of the bigger case series just published last month, or a couple of months ago now, from Jack Roots and colleagues, looking at outcomes in 39 cases, and this is one of the largest ones, looking at the responses in terms of gas transfer, lung function tests, and also CT scan scores to immunosuppression. And in general, immunosuppression is working in the majority of patients, although with some relapse and with some treatment-resistant disease. Assessing treatment response is another challenge. And again, to come back to the Frontiers series, some very nice data here from Borferang in Norway, looking at the value of positron emission tomography to be able to quantify disease and therefore to assess disease response or lack of response in a non-invasive way. One question which does come up is whether optimization of immunoglobulin alone is sufficient to treat GLILD. And certainly there is some evidence illustrated here on the slide that in patients who are treatment naive, initiating them on effective antibody replacement can cause regression of GLILD changes. However, it's also clear that GLILD can develop and progress on people who are effectively replaced. And so antibody replacement alone, absolutely necessary, but is not sufficient to give control of GLILD. Coming back to a clinician survey, this time in the UK, the most common induction regimen is with high-dose oral corticosteroids. And when people are using second-line agents, they're using commonly mycophenolate and rituximab. But that begs the question, who to treat? And the consensus here was that where people are seeing deteriorating lung functions in terms of the trajectory in lung function over time, particularly where those lung function tests are abnormal, but even if they're normal, if they're still declining, then that's when treatment should be started, irrespective of the presence of symptoms. And there's clear consensus not to treat in people who just have an incidental finding of this on CT. So in other words, people without symptoms, with normal lung function and stable lung function, probably don't need treatment. But you can see there's a good group of people still there in the middle where there was no consensus about whether or not to treat. In terms of assessing response, if we're not going to look to the future with PET scanning, as I've shown you already, then the commonest ways to do that are looking at lung function, and typically the gas transfer or DLCO or KCO testing is the best way to assess a treatment response. And certainly that's what we use here in London, seeing about 6 in 8 patients respond to higher dose steroids. More on second-line therapy, azathioprine, rituximab and mycophenolate in this UK-based data were the commonest second-line agents which reached consensus to be considered for use. And there is evidence for this combination chemotherapy approach, again, a classic paper here by Jack Rouse and colleagues, providing evidence that targeting both T and B cells may be associated with the best evidence. Again, it's a small trial, and many of these patients had already failed existing treatments, so we need to interpret the data in the light of that. And again, some more data here on rituximab and azathioprine, illustrating the changes that you can see in CT scan. Targeted therapy also is a really exciting development as we start to understand more and more about the genetics. Then people with LLBA deficiency, CTLA4 loss, may respond to treatments such as abatacept, which are specifically targeted against such pathways. And as we understand more about the genetics of this complex condition that we call CVID, I think this really is the way forward for the future. And some evidence, therefore, in people with monogenic disorders that bone marrow transplantation may be of benefit, although clearly not without risk, and in particular in those who already have existing lung damage. Because of this absence of research, we've recently completed a research prioritization exercise. And some of you may well have taken part of that. If you did, thank you. And we were supported by IPOPI as well in doing that. And that really had the patient voice at its center. These data are complete and submitted, but not published yet. And the top 10 research priorities are listed there for you in terms of their overall rank, their ranking by patients, and their ranking by clinicians. And you can see that the top questions are really pretty simple. Hopefully we may have some data emerging from studies such as still patching to answer some of these. But for the moment, there really is uncertainty out there about whether corticosteroids or alternative agents are best for inducing remission and then maintaining remission. But an awful lot of unanswered research questions, which is a network we hope to be able to address. Finally, then, just to touch on lymphoproliferative disease, because lymphoma can occur in the lung in people with CVID. And I want to highlight this very recent publication as well, looking at lymphoproliferative disease in CVID. And I just draw your attention to the proportion of people developing those complications in people with underlying respiratory disease. And you can see that in general, if you have underlying respiratory disease, you are not at increased risk of developing lymphoma. You may be at increased risk of developing lymphoproliferative disease, but that's probably the GLILD coming in again. So we need to be alert to the idea of lymphoma in the lung in people with CVID, but it doesn't seem to be more common in people with pre-existing respiratory disease. So that was a rattle through. I'm sorry if I've hurried, but there was so much to talk about here. So I'm going to end with some summary slides there, which hopefully are the key messages that I'd like you to take away from today. And to give some time for questions, I'm going to finish there. And finally, thank IPOPI for the invitation and CSL Behring for making this possible. Thanks very much.
Thank you so much, Professor Hurst, for this very interesting presentation with many learning points. Now we will take some questions from the audience, and I'd like, and also Dr. Mr. Al-Marawi, yes, you're there with us, thank you. I'd like to highlight this first question, very preliminary one. It's always difficult with this word. This one here, to Professor John Hurst, why do you speak about primary antibodies instead of PIDs? Why this preference at first? Would you have a short answer on that, please?
Yeah, I think the immune system is super complex, and PID is a really useful term for encompassing problems in all sorts of the immune system. So, for example, in the neutrophils with CGD. But actually the topic of lung disease and CGD would be another topic in itself. And so within 30 minutes, one has to restrict what one presents. And that's not to say that the others aren't important. They are just as important, but they have to be a topic for another day.
Okay, thank you so much. I think it was clear. Let's go about first question about frequency. How common is it globally that lung specialists recognize that lung problems could be due to a PID, in your experience?
So I'm amongst friends here, right? So I can talk openly and honestly. And lung specialists are not good enough at identifying people with primary immunodeficiency early enough. We have to think about SPIR, right? So severe infection, persistent infection, unusual infection, recurrent infection. But that is not coming through in training our early career respiratory clinicians, despite all the efforts of IPOPI and enthusiasts like me, and we need to do better. And not just for respiratory specialists either, but for primary care too.
Yeah, and Dr. Malawi, would you say the same for children?
Yes, absolutely true.
Absolutely. Okay, so let's move to prevention. Does recurrent sinus infection lead to lung problems in antibody deficiencies? And how to monitor this in case?
That's a great question. So there are good and clear relationships between the upper airway and the lower airway. The nose and sinuses are the air conditioner for the lung, if you like. That's their function. And when the nose and sinuses aren't working properly, dry, cold, unfiltered air gets down to the lung. So maintaining upper airway health, super important. Thinking about different treatments to do that, absolutely. But the question is really good and really important point.
Okay. Dr. Marawi, any comment in addition?
No.
The same? Okay.
Yeah.
So, let's have a question linked to the situation, the COVID-19 one. Now that wearing a mask is becoming a standard in many countries in the world, would you recommend using a mask to prevent breathing fungi, bacteria, etc., in patients with lung problem? And can mask that you are wearing for the COVID prevention improve lung problems?
Lots of different questions in there, and it's a really complicated area. Wearing a mask tends to protect other people rather than protecting you. Yes. That's the first thing to say. But if you are vulnerable to developing respiratory infections and you can wear a mask comfortably, then that might be something that you want to consider to do. Actually, it's been really interesting because as people have been shielding from coronavirus, we've seen the number of people developing respiratory infections plummet because they've also been prevented from catching all the usual things that cause infections like rhinovirus. And so understanding what people will do long term is super important. But we've just completed a survey of that in the UK, actually. And for people living with standard lung conditions, not in the context of antibody deficiency, not that many are willing to continue to wear a mask at the moment, at least without better evidence that it's going to make a difference. And if you've got difficult lungs, wearing a mask can be unpleasant.
Okay, so let's move to treatment now because we have some question and some tricky one, I guess. What a patient can do after one or more bronchiectasis that evolve in a long airway restriction to try to improve the lung functions?
So antibody replacement, get that right. See a physiotherapist. Make sure that the sputum clearance is as good as it can be. If there is narrowing of the airways, then we do have medicines that can help. They're called bronchodilators, and they come in 2 different classes, and sometimes you can get the 2 different classes in the same inhaler. So for some people, those bronchodilator medicines can help. We also have medicines which can make the sputum more liquid, so it's easier to cough and to clear. And that kind of treatment can also help some people. So if you have bronchiectasis and you're breathless or you have trouble with sputum, speak to your clinician about that. And if you're a clinician in immunology and you're a bit stuck, speak to your respiratory clinician, because we're always very nice.
Yeah. Dr. Madawi, any comment for children? No?
Same thing for children. And I'm guessing also, as for patients with cystic fibrosis, maybe we could also recommend physical activity like sports, and also, John, what do you think about autophysiotherapy, like, self physiotherapy? Is that something that you would recommend?
Yeah, that's a great question, Nizar. Thank you. So I think understanding how you can clear your sputum most effectively is the critical thing here. And for some people, that's relatively easy. For some people with more extensive disease, it's not, and they might need specific physiotherapy regimes to be able to do that. And we can certainly learn a lot from cystic fibrosis and how they do things there. So regular exercise, well, that's good for all sorts of reasons, but it's also good because it helps to clear the phlegm.
And always linked to bronchiectasis, is there any advice you could give to a patient who don't have access to immunoglobulins in countries where this is not possible, or in moment where this is not possible? Is there any advice you can add on yours?
So that's a very far from ideal situation, because that's always going to be my first choice, to treat a cause where there is one. But that doesn't mean that the other components of bronchiectasis treatment are not going to be effective. So I'm still going to say sputum clearance and physiotherapist, and I might put a greater emphasis on antibiotic prophylaxis, for example, in people who are otherwise getting lots of infections. Always it's a risk and it's a balance, but that might be something to consider more actively.
Okay. There we have a question from a physician. I have a patient with hyper-IgM managed by a pediatric pneumologist. The consultant is convinced that the patient has ABPA and that the IVIG we are giving is fueling an immune-induced pneumonitis. And are there any literature that support this?
Nizar, do you have comment? I can speak.
No, I don't know. I don't know about this.
ABP, me neither. No?
Sorry.
No.
So
okay.
I'm also not aware of any data. I would just make the point that ABPA, if you're not familiar with that, allergic bronchopulmonary aspergillosis, very, very difficult diagnosis to make. One of the ways that we might make that diagnosis is by looking at the serum IgE level. And here we're talking about a group of people where that assay is going to be not interpretable in the same way, right? So, so we've added additional complexity to something that's already a complex diagnosis.
Yeah, okay. So I think that's now we've reached the end of this webinar. If we have some other questions, we will answer them by written to the people who have asked them, as we do usually, so don't worry about that. I also would like to thank once again CSL Behring, who made this webinar possible. On behalf of IPOPI, I would like to say a warm thank you to you, Professor John Hurst, for this excellent presentation and for also the answer that you provided together with Dr. Nizar Malawi. Thanks again to all of you. You are numerous, I have to say, for attending this IPOPI webinar. If you gave a minute to spare, we engage you to share your feedback on this webinar by pressing the link shared on the screen. It should appear very soon. And the link is also posted in the chat. Please note that you will be able to see the recording on IPOPI TV within a couple of days. We encourage you to share it as much as possible to those who you think will benefit from it.